Yes, thank you, Braun, for asking me today to do the symposium. So I'm going to talk to you a little bit about line flushing. And when I say line flushing, I mean giving sets of IV therapy, because you might know NIVAS produced some guidance last year. I think it's the third version last year. And so just kind of talk about how you can incorporate that guidance into your IV therapy practice. So the agenda today, we're going to talk a little bit about the underdosing and the guidelines, the implications, and then what we've done in my practice, in my hospital, to try and deal with that. So I don't know if any of you are aware of this. You might have seen the guidance from NIVAS. You may have heard, we've spoken about it at the conference this year and last year, actually. So underdosing has become an issue. So, you know, I've been doing IVs for nearly 20 years now, and when I was trained to give IV therapy as an adult nurse, I was trained to draw the IV up in an IV room. If it was an infusion, run the infusion through, get it all checked, go to the patient, hook it up, ANTT, give the infusion, take it down, flush it, throw away the giving set, away you go. I was never taught to flush the giving set. And so unless you work in oncology or paediatrics, was anyone here taught to flush giving sets of IVs? So I'm probably seeing about 10 hands in the room. And so it's a thing that's kind of occurred over time that we didn't really know that it was a problem, right? It's one of those mythical things like glove use in the NHS that has evolved over time. Everyone does it. No one really knows why they do it, but they just do it because it's something we've always been taught to do. So flushing IV giving sets has now become something that we need to think about doing, because what we do know is a percentage of the drug that we're giving in that infusion giving set is wasted, and that potentially has implications to the patient and the success of the treatment, the therapy that we're giving them. And we know a 100ml bag of diluent with the drug in, up to 20% of that drug is lost in the giving set, and if you're using a 50ml bag, up to 40% of the drug can be lost. Obviously there are variables there, the length of the giving set, the type of giving set you're using, etc. But essentially, some of that drugs we're not giving the patient. So we're not giving them the whole prescribed IV therapy. So there's implications there that we need to think about. So short-term intermittent infusions are often administered via pump, hopefully by a pump, because we know pump infusions are safer, because, you know, there's a machine that will tell us what's going on, hopefully. But even with gravity as well, same thing, we're not flushing the giving set, right? Even without flushing. Now, some things we shouldn't, like blood, for instance, we don't flush giving sets in blood for a reason, so we shouldn't do that. If it's normal saline, it probably doesn't matter. We don't need to give them that extra 20 mils, because you could give them a 20 mil flush into the cannula, which would then replace what you're missing from the giving set. But it's the IV therapy, the drug in the diluent bag, that we need to consider. Now in chemotherapy, any chemo nurses in here? Shout out to you, because you've got this covered. You already use, or you should already use, some sort of infusion set where you have the ability to flush the infusion line, right, or piggyback it on. So great for you. You don't waste a drop of that chemotherapy. Paediatrics as well, another area where you're quite good at flushing your IV sets. But in adult nursing, to be honest, we're rubbish at doing it. We're not really doing that at the moment. So NHS England have said the risk or harm due to underdosing administration sets of small volume infusions is not followed by a flush was raised with the National Patient Safety Group. So this was raised, this issue, about 5 years ago. I think it was about 5 years ago, by the then head of the Patient Safety Organisation, as a potential risk to patients. And there were some papers that have been published about that and about the potential risk, which was around the time that NIVAS thought we'd better write some national guidance for you guys, because otherwise, you know, you're going to all start panicking because you're not flushing your IV giving sets. And the first variation of that guidance was we weren't really sure whether we should flush the giving set. But actually there's more evidence now to show that we should be trying to flush those giving sets. And so we've published it's on the NIVAS website. You can download that for free, that flushing guidelines. Medusa, injectable medicines guide, most 95% of us follow, recommends that we follow the flushing guidelines from NIVAS and we flush our IV giving sets. And the Royal Marsden, after completion of an intermittent infusion, an appropriate diluent solution should be administered via the administration set, essentially saying the same thing as the NIVAS guidelines. Here's a picture of the guidelines. So there's a couple of options you've got. Essentially, you need to get the drug from the giving set into the patient. Now, on the face of it, there's no easy way of doing that without having to maybe respike the bag or use a syringe driver, but you're still going to have to break that sterile chain right between the bag and the giving set. You have to respike it. So we want to try and avoid that if we can, because it's not ideal. So method one, basically take the old bag off, respike a new bag on. Potentially, if you're going to respike a bag, a 50ml or 100ml bag of saline, that's going to cost a bit more to your organisation. You might overload the patient with fluids as well. It will take longer to give the infusion. So there's drawbacks on doing that, really, of that respike of that bag. Even if you're only going to give 20 mils of that solution and throw away and discard the rest of the bag, it's a waste. It's a waste of money. Sustainability-wise, the plastic involved in that bag of saline is going to, cause you some angst as well because of the environment. So really, is there a better way? Oh, well, there is a better way, in actual fact. So we use Braun Infusion mat pumps in our organisation, and Braun actually produce an IV giving set with a needle-free connector adapter. Here is one. Whoops, so bag of fluids, needle-free connector. And so once your infusion has run through, and this, even if you don't use their pumps, you can still use these gravity sets if you're not using a pump and you're using a gravity set. So once the infusion's run through, this is a filter at the bottom that stops any more fluid running through, so you don't get any air in the line. And then you can fill here, you clamp the line, then you can basically put 20 mils in here of saline or whatever, dextrose, whatever your infusion solution is, and then you can run the giving set through for another 20 mils. So it's nice and it's a closed system, so you're not having to respike anything, so it's a less of a risk of infection there. It's the same giving set, so we're not having to open another giving set or use any more plastic, and it's just a 20ml flush that goes into the chamber. So actually, this is a really good solution for this problem. Now, I'm not the only one that thinks this is a good idea and that uses in our clinical practice. There's another trust in the UK who have done a big project on these sets, actually, and they looked at all the giving sets that they were using and the drugs that they were giving and the drug doses that they were wasting and the cost of that to their organisation. And they worked out it was around £25,000 a year in drug wastage alone. That doesn't take into account the patient, the cost of the patient, because what we don't know is, and we can assume, that if we're not giving the full dose of drug to the patient, particularly in an antibiotic, then potential there is that we will have to extend the duration of the whole treatment because we're not optimising the patient's treatment to begin with, underdosing them. They might not get the full benefit of that IV therapy. So it's something to think about in your organisation, particularly when you think about your sepsis care bundles and that sort of thing. And talking, antimicrobial stewardship, we know we need to give the antibiotic regular times, the full dose, to ensure that we get a really constant therapeutic level in the blood plasma. If we don't give the full dose, it can dip underneath therapeutic range, and we've got peaks and troughs. We're losing the benefit of the antibiotic, and that can be a real problem, actually. So, in terms of my own journey for this, and it kind of evolved through the work we did through NIVAS, We introduced the line flushing with these giving sets in our IVAS unit, the Infusion unit. So we've got this an Infusion unit, it's all non-chemotherapy drugs, 22 chairs, and we give monoclonal antibodies, blood transfusions, antibiotics, fluids, zolentronic acids, all basically outpatient infusions. Are very expensive drugs that we're giving. And so we thought, actually, we're probably wasting a lot of money and also not doing we're doing our patients a disservice because we're probably not giving them the full dose of their IV therapy. So we introduced these IV giving sets to the patient, and it was a very seamless transition. The training involved in using these sets is very minimal. They're very easy to use. We use the pumps, but you can use, like I say, gravity as well, so you don't need to just use the Braun pumps if you don't have them, but obviously they're a good pump as well. And it's, we're a high usage of IV therapy in our organisation, so despite the cost of the drug and the patient's chances of successful treatment, the alternative would be to hook on a 100ml bag of saline to the giving re-spiker bag. That was more cost and also sustainability-wise with the plastic and the risk of infection. So we found it very easy to use, and this is basically how we did it. As I said, you've got your IV giving set. Once it's run through, that filter means that you don't get air in the rest of the line past the drip chamber. You then fill the drip chamber up with your flush for the giving set, 20 mils, and then we just run the pump for a further 5-10 minutes, however long, and so it couldn't be easier, really. So our data then, from 2019 to 2021, we've seen an increase in our infusion activity. Last year we did over 11,500 infusions in the year, day infusions, and the list of drugs there, the list of drugs is on the left-hand side there. If you were to add up the cost of the residue drug in the giving set, it would be a lot of money. You can just see the price of one of the vials of just Privigen alone that we get is like £1,300 just for that one bottle. So, and these patients are reliant on these drugs every 3 weeks or every 2 weeks to function. So we want to make sure we give them every drop of that drug to ensure a successful outcome for the patient every time they visit. So next steps for us, the next step is to introduce these IV giving sets into our critical care environment, because we know that in that environment they don't flush their IV lines actually, and so when they're giving infusions they're discarding the remaining drugs, including antibiotics actually. So I think we need to focus on those critically ill patients, because obviously we want to maximise every chance of successful treatment for them, but also the giving set gives us the opportunity to use the same primary line for multiple intermittent infusions rather than piggybacking onto the vascular access device. And you can see in the image there, there's one container full of the fluid that's being administered, which you can then clamp off and then attach a second line onto that giving set. So you're still maintaining a closed system, a bit like you would do in oncology when you're giving your chemotherapy and then you're flushing the line as well. So this is our next part of the journey. This is what we're going to be trialling, and hopefully it'll be successful. It'll be time saving on obviously as I said, the drugs that might be wasted, and improving patient outcomes, and plastic reduction. It's really unnerving, that noise. You can hear that, right? It's not just okay. It's not just me. Making a case change. So current practice in critical care, as I said, use and discard one pump set per intermittent infusion, and one pump as one primary line. We can change the set every 72 hours, and use that for secondary line infusion. So you can see multiple opportunities to save money, reduce plastic use, sustainability, and also, as I said, patients benefit with better outcomes. And then practicality cost neutral. So for us, it's it's £1,000 cost investment. Patient receives a total dose of IV therapy, avoid drug wastage, and plastic reduction as well. What will be next? Looking at our community, so our OPAT service, making sure our OPAT patients get full advantage of the prescribed antibiotics, looking at paediatrics, where we are giving infusions, and eventually a trust-wide adoption of these new infusion sets. Thank you for listening.